Good afternoon, everybody, and welcome to this intimate last session of cardiac imaging. I hope colleagues will arrive because this afternoon we are covering a lot of exciting topics which are part of the clinical routine you may have to deal with. And particularly this afternoon, my lecture is dedicated to MR imaging of myocardial inflammation, which is a very, very common indication to MR and even to CT in some cases. This slide here, there is a problem with the screen? Okay. This slide here shows, let's say, the simple anatomy of the pericardium and its relationship with the heart, with myocardium. If you look at the histological stain here, you notice there is a single line of mesophyseal cells here separating the pericardium, which is this elastic membrane, from the myocardium through a certain amount of loose connective tissue and fat tissue. So the structure is very simple, but for some reasons, pericarditis and myocarditis are completely different processes, and not very often there is a communication between the two. I'm speaking slowly. I was asked to proceed slowly because of the translation, and we take our time. This slide here shows a picture of Italian cardiac MR organization. We published this registry in 2013. I was the coordinator, and it's interesting. We were discussing with colleagues before. We have, according to this registry, 44 centers in Italy doing cardiac MR. We managed to screen in 6 months almost 3,500 patients. And why am I showing you this? Because it tells us what is more commonly addressed in Italy for cardiac MR evaluation. So basically, which pathology are more commonly addressed to our attention. This morning, we talked about sudden cardiac death, about ARVC, which is the first indication in Italy, and this is slightly different from other registries. Myocarditis is number 2. About 11% of requests for cardiac MR are addressed for myocarditis. So look this case, it's written in Italian, sorry, I thought I changed, but it's even simpler for you. 40-year-old male with retrosternal pain, positive enzymes, selective coronary angiography, which was negative. It was addressed for cardiac MR. If I ask you to look at the CNA here, there is a normal function of the left ventricle, no dilatation, no abnormalities, nothing to rely on. But moving forward, something happens. There is a signal intensity abnormality here on T1 weighted imaging, which is much, much more pronounced. On T2 steer, you see this tria of high signal intensity involving the lateral wall of the left ventricle, consistent with edema. So this is an acute process. And we also have lead enhancement matching with this. So we have edema here. We have lead enhancement in the basal part of the left ventricle here, also depicted on short axis. If you look at this slide, it's very important. It tells us why this is not an acute myocardial infarction, but why is it an acute process? We have edema here, meaningful of an acute process. We have lead enhancement, which is typically sparing subendocardium, as shown here, and epicardially distributed. So with imaging, we are able to screen and to look at different processes in myocarditis, mainly consistent with myocyte necrosis, tissue edema, and hyperemia. Just to tell you the story, this manual drone was done by a resident working with me. She's a probably better drawer than radiologist, but we published it because it really summarizes what to look for in acute myocarditis. So there is an evidence that MR is doing a great job, but guidelines are going in a different direction. These guidelines were published in 2013, so only 3 years ago, by a working group including cardiologists and pathologists. And what emerged from here is that the diagnosis of myocarditis is still, according to well criteria, based on endomyocardial biopsy. I will try to show you how and why biopsy is not playing a role anymore, except in highly selected cases, and why MR is somehow superior to histology. But on the other hand, if you look at guidelines, it's incredible to note that these colleagues, mainly Italians, and it's a multi-centric document, they state even to repeat biopsy if necessary to drive etiology-directed therapy and sampling errors. So for some reason, cardiologists are still convinced that endomyocardial biopsy is doing a great job. But what happened? In this nice paper, still from 5 years ago, it's a sub-journal of Circulation. It's called Circulation Clinical Outcomes. What they did is to follow, for a 5-year period, a group of patients with viral myocarditis, 514 patients. And if you look at the algorithm here, what it shows, green is biopsy, red is MR. There has been a trend towards a reduction of MR, of the biopsies over time, with an increase of MR examinations. So MR is becoming more and more and more important. And what is even more interesting is this editorial published in 2006. This guy, Kenneth Bagam, is one of the authors of the guidelines for endomyocardial biopsy. And if you remember from pathology studies, endomyocardial biopsy are defined according to the so-called Dallas criteria. These Dallas criteria basically assume how to establish the diagnosis of myocarditis. And this colleague was mentioning these criteria are dead because MR came and MR is overcoming histology, which is one of the few cases in human pathology in which you have an imaging technique better than biopsy. Why this? Because endomyocardial biopsy is positive only in 10 to 25% of cases. And this is related to the fact that if you go to do biopsy, usually you withdraw the subendocardial layer, whereas, as I showed you, myocarditis is more often subepicardial. So if you want to see and to take the subepicardium, you have to do a deep hole in the myocardium and ventricle, making the procedure highly, highly risky. Secondly, there are sampling errors. It depends on when you do take the sample tissue. And this is extremely important. I showed you the first case, but I will show you many others. The typical location of myocarditis is the lateral wall of the left ventricle, at the base, and subepicardial. So it's a thin wall in which biopsy can be highly risky. So for these reasons, really the gold standard changed. Another case, another clinical scenario, different onset, 57-year-old male. This man had acute heart failure. Troponins were almost normal. He had a negative selective coronary angiography and again underwent MRI. So if I ask you to look at these images, they look completely different from the first case I showed you at the beginning of my lecture. Because what happens here is that there is a clear heart failure. You see, this morning we was discussing how to measure kinesis and intrinsic ventricular motion. And for some reasons here, the subendocardium is not moving. There is a torsion of the apex, but overall ejection fraction is low, is in the range of 20%. There is some pleural effusion here probably, not clearly depicted, and the heart is doing bad. What is this? It's a myocarditis. So this starts to tell you how much this disease can be polymorphic. And if you look at integrated imaging here, what we note here is that there is a T2 steer, again, showing edema in the inferior lateral wall. Edema is more diffuse than previously. Latent enhancement here, again, spares the subendocardium. And we also have mapping techniques we discussed this morning, which are able to measure the changes in T1 relaxation time. And here everything is red on the same location, which means that there is a diffuse necrotic involvement, either on native images and after contrast. So myocarditis is a syndrome rather than a clearly established disease, and this is something that we have to take into account. Which are the enhancement pattern to look at, and why and how could we recognize myocarditis? Remember this case, because in the final part of my presentation I'm going to show you something different, but this is the first scenario we may have. I already discussed subepicardial, no more to add. Pattern number 2 is mesocardical, mid-wall enhancement. Like in this patient, we have a stria of high signal intensity in the septum, which is following the interventricular septum and something on the lateral wall. Second pattern. And pattern number 3 is called patchy, because as you note from the screen, we have multiple foci of high signal intensity predominantly involving the lateral wall of the left ventricle, which symbolizes an advanced myocarditis. So 3 patterns to remember. The common, let's say, pathway here is that there is no endocardial involvement, which means that there is no ischemic process. What can happen to late enhancement? This shows a patient in acute phase, first line, and after 4 months. And what you note here is that there is a regression of late enhancement from the first to the second study, because the process itself reorganizes. There is a reorganization, there is a fibrotic replacement of the ventricle, which causes a reduction of late enhancement. And this is something to really take into account. Let me move to this further slide. Here. Why MR, and what is the value, the diagnostic value of MR in myocarditis? Is extremely highly well performing. Literature is full of papers, either biopsy or non-biopsy validated, and sensitivity, specificity, and positive and negative predictive value of MR is very, very high. The problem is that there is a large variability of diagnostic performances. Most of the studies do not have endomyocardial biopsy validation, and still there is not a large multicentric trials on myocarditis that probably would be nice to set up, even cooperating in an extra-European level. So what I will talk about and how to develop the topic, I will skip the technical issues because it's really far behind the scope of this presentation. But it's interesting, first of all, to rely on the large variability of involved agents in myocarditis. Look at this. What happens is that depending on the agent involved, myocarditis may cause 2 different processes. The first process is apoptosis. For example, enteroviruses are responsible for an apoptosis mechanism in which there is what is called programmed cell death, whereas in most of the cases we may have necrotic involvement. Why should we care as imagers on the mechanism of cell death? It's very important because whenever there is apoptosis, there is a programmed cell death, there is no late enhancement because fibrotic replacement is minimal, and we don't see much in processes in which there is an apoptotic involvement. This is very important because enterovirus myocarditis are typical for pediatric patients, and sometimes we do have a clear clinical onset and clinical picture of myocarditis with a negative MR. So one indication that we had, we published already 3 years ago in JACC imaging, is that the mechanism of cell death may have an impact on patients, on the accuracy of the method. Secondly, also very important, is about edema. I told you edema is a marker of acute disease, so if you ask me which protocol would you use, always do T2 steer, short-term inversion recovery in patients with acute myocarditis. You will always see this high signal intensity stria located in the lateral wall of the left ventricle matching with late enhancement. Usually, within 4 or 5 weeks, edema resolves, and in the distant phase, in the follow-up phase, we don't see anything in terms of high signal intensity, and that's exactly what we should look at to rule out an acute versus a chronic process. This tells us what is edema. Edema is an integral part of the acute inflammatory response of the myocardium, and this principle provides a base for utilizing T2 imaging to identify myocarditis, as I told you. In contrast to ischemic syndromes, where the myocardial injury is focal, in myocarditis we may have even a diffuse process. And of course, we have to quantify edema, and that's also quite important. Let me skip this, it's a little out. The other topic I would like to talk to you about is the large variability of clinical presentations. I'm sure, even if some of you is not really expert of cardiac imaging, if I ask you, how do you imagine acute myocarditis, you would say, I imagine a patient with a syncope, with acute chest pain, troponin raise, ST elevation, etc., etc., etc. Unfortunately, it's not like that. Clinical presentation of myocarditis is complex. It's multifactorial. You may have a spontaneous resolution, so some patients are merely asymptomatic. This occurs in most of the cases. You may have an acute non-fulminant form or an acute fulminant myocarditis, like the case I showed you before. And this, unfortunately, may conclude in acute heart failure and sudden cardiac death, which is one of the manifestations of myocarditis. Again, why should we care about this clinical insight? Of course, we want to be clinical radiologists as we are competing with cardiologists. But what is also extremely important on this regard is to consider how clinical presentation may have an impact on the diagnostic performances of MRI. So we did another study with 118 patients with suspected myocarditis, and we categorized patients in 3 groups. Keep in mind, because these 3 manifestations have been perceived by the guidelines, and today I'm honored that this paper was considered in the new guidelines of myocarditis, because there are basically 3 possible onset of disease. The first is the so-called infarct-like pattern, which is exactly what I just told you: chest pain, fever, ST changes, and troponin elevation. Very simple, clear, classic. Second pattern is the cardiomyopathic, which is characterized by left ventricular dysfunction with a low ejection fraction. ECG might be even normal, and patients present signs and symptoms of heart failure. And the last pattern is the so-called arrhythmic, in which patient has simply arrhythmias at the onset of disease in absence of systemic signs of inflammation. So if I asked you, let me skip this, what sensitivity do you expect to be between the 3 patterns, and we move to the next slide. In infarct-like myocarditis, MR is doing very, very well. These are matched to the so-called JACC white paper, which is the Bible of myocarditis. And in pattern 1, if you have an infarct-like presentation, accuracy of MR is in the range of 86%, very high. In heart failure presentation or cardiomyopathic presentation, MR is doing also very well. Accuracy is 76%, higher than the average. But unfortunately, we fail to see myocarditis in patients with arrhythmias. And that's something to keep in mind, because one of the presentations we have a lot of times is new arrhythmias in an asymptomatic patient without chest pain, without troponin motion, and this is not only an ischemic correlate, but may also imply acute myocarditis, and MR is doing very bad in these scenarios. One example here, another cardiomyopathic patients with a lymphocytic myocarditis from the paper I was telling you about, 48-year-old male with recent onset of dyspnea. Ejection fraction is slightly reduced, and diastolic volume is 188 milliliters. And if I ask you here, there is no lead enhancement, there is no edema, just a minimum pericardial thickening. But according to the criteria we are using in clinical practice, this is not an myocarditis, so MR failed here. Another example, arrhythmic presentation, hypotension, palpitations, and again, lead enhancement and edema completely negative, unfortunately matched with an histological diagnosis of myocarditis. And finally, we already mentioned mapping. There is no time to discuss this, it's a little more advanced, but as I told you before, today the diagnosis of myocarditis needs to be integrated with utilization of this technique, which allow to measure changes in T1 and T2 relaxation time, very, very critical in myocarditis. It was defined by the new North Star of myocarditis and of cardiac imaging, and I totally agree. For those of you we were discussing before starting the session who wants to start or to restart cardiac imaging, I would highly recommend to use and to ask for these sequences, because today most of the clinical activities in cardiac MR requires integration with mapping. So I'm going a little slowly, but we started a little late. I finished the first part of my presentation. The second part regards pericarditis and, in general, pericardial disease. What about pericarditis? It's a complex disease. Diagnosis of pericarditis is not simple. You know the pericardial rub we studied during medical school, meaning pain during inspiration is very commonly present. There may be acute chest pain, ECG changes consisting with T inversion, etc., but in general, not always it is simple to recognize acute pericarditis. But for some strange reasons, my research since 18 years have been devoted to pericardial disease. So it's a topic I like a lot, and more there is an ongoing focus on this and emphasizing an added value of MR because it gives additional information as compared to MR. And this slide I'm showing you was shown at RSNA by a famous colleague who was presenting an overview about pericardium, and he called me the pericardiologist because since 2004 I did a lot of research, published a lot about acute pericarditis, and it's a topic I like. So give me the opportunity to spend the last 10 minutes of my presentation talking about this. This is a review we wrote 4 years ago on radiology, summarizing what we just mentioned about. Acute pericarditis, how is it the diagnosis done? It's just shown here. The various changes that you should look at are depicted in this patient. Thickening on T1 of the pericardial layer with effusion. This is a T1 turbospinago, so fluid is dark. For us radiologists, it's easier than for cardiologists to recognize signal changes. This is lead enhancement imaging with thickening and enhancing layers, pericardial layers, with a minimum amount of effusion confirmed at different planes. There are a lot of causes of pericarditis, post-infarction, mediastinal therapy, radiation therapy. More and more we see those cases after neoplasms, acute myocardial infarction, trauma, surgery, etc. And MR is giving, again, a fantastic overview of what we studied from the book of pathology. Look at this case. I don't know if you remember the term pericarditis sicca is the form of inflammation in which you have, as shown here, a diffuse edema of pericardial layers on T2, as shown here, thickening of pericardial layers with enhancement of pericardial layers, matching this series of images. So you don't have effusion, you just have a thickened edematous enhancing pericardium, which is typically configuring this presentation of pericarditis sicca. Or we may even have other presentation. Look at this. This is an acute myocardial infarction. There is, in this patient, transmural late enhancement here in the infralateral wall of the left ventricle at different levels. And this transmural infarction is associated with enhancement of pericardium. So pericardium is enhancing with an infarction because there is a damage of the layer, and this causes spread. And we can even have opportunistic disease, mycotic pericarditis in this HIV-positive patient, honestly showing a diffuse effusion involving the ventricles with an enhancement of the layers, not different from what I just showed you. And this is very common. But there is also constrictive pericarditis, which is another story. In constrictive pericarditis, we have to look at morphology and diastolic function because there is a thickening of the pericardium, which becomes unelastic. Very often have calcifications, and this causes an impeding to the diastolic relaxation of the heart, contracting bad, and with a series of abnormalities we can see. Very often we ask our students, our residents, what is the pericardium useful for? And they are not able to answer. Interestingly, physiology of the pericardium is extremely complex. We do have mechanical functions, membranous functions, and ligamentous functions. And if you have any sort of disease like constrictive pericarditis, all these go away, and a lot of pathophysiological consequences may occur, and you have to keep in mind, of course. This is a typical eggshell appearance because we are multimodality doctors, we are multimodality specialists. I don't know how often have you seen a case like this. It happens sometimes in clinical practice. It's an eggshell pericarditis. From CT you perfectly see calcifications that you are not able to see with MR. On the other hand, these are typical MR changes, consisting with a thickening of the pericardium here, tubularization of the right ventricle, which becomes smaller, and sometimes pleural effusion related to the overload of the right ventricle. This is morphologically what we see in pericarditis. Of course, we may have even enhancement of the pericardial layers, so contrast is useful in these patients because there is a diffuse gadolinium accumulation within the layers of the pericardium, which do not add too much to that. Constrictive pericarditis may be even focal. Look at this patient here, for example. There is a single thickening of the pericardium at this level, causing dramatic consequences in terms of diastolic function. So the diagnosis, again, is not obvious, it's not simple, and a lot of things come out. And talking about pathophysiology of constrictive pericarditis, what happens when the pericardium becomes thickened and is not working? There is a dissociation between intrathoracic and intracardiac pressures. So the heart is not relaxing properly. This causes an increased pressure to the septum and what is called paradoxical motion. Look here, because it's very typical. I think you remember from medical school, and you have probably seen cases like this. If you look at the interventricular septum here, there is a sigmoid torsion of the ventricle appearing in the end-diastolic, in the diastolic phase, consisting with a sigmoid motion of the septum. This can even be enhanced, asking the patient to breathe in. We optimize this real-time technique, again, implemented in most MR scanners. Patient is asked to breathe in deeply, and we better see the paradoxical motion of the septum because of the upward motion of it related to the increased blood income. So we may even have normal pericardial thickness. The diagnosis in this case necessarily requires functional imaging and deep inspiration by the patient. Let me go maybe rapidly to the conclusion, because I would like to discuss with you some cases. Already half hours passed, and I think it's more useful probably today even to discuss some cases. And I'm coming to my conclusions. First of all, we talked about myocarditis. You should consider myocarditis as a syndrome rather than a clearly defined pathological entity. As I told you, myocarditis may have an infrared-like presentation. Myocarditis may be associated with other forms of disease like acute heart failure or arrhythmias, and it's much more complex than we can imagine. Standardization of the protocol is necessary. I told you, you need to do T2, you need to do gadolinium, you need to do function, and today you need to integrate it with the use of mapping techniques. There have been some techniques which have been overcome today, like early gadolinium enhancement, which is the most controversial tool to be used for. We can have histology, but as I told you, more and more histology is overcome by clinical evidence and by MR, and so it's one of those cases in which I would say MR is doing better. Clear definition of acute versus chronic is also necessary, and we use edema on that regard, and mapping is also quite important. About pericardial disease, I told you that it is important to measure the thickness, to use contrast to look at enhancement of pericardial layers, and to use T2 sequences to measure edema, exactly like we do in myocarditis. So, this was my last slide, but I would directly move to the case discussion because probably it's more interesting, and please, if I would ask you to interact because it's late afternoon, it's the last day of the Congress. Let's make it friendly and as more as possible with an open discussion. This is a case, actually the 7th case I meant to present to you. I called the anxious lady. As doctors, very often we have patients who are labeled as anxious or not before starting everything. And this lady came to do MR, being labeled by the cardiologist as an anxious, pressing patient, etc., etc., etc. She was a 47-year-old female, smoking 1 packet of cigarette per day. It's not really light. Non-diabetic, hypertensive of dyslipidemic. She had a positive history for ischemic heart disease. That's very important. She was admitted to emergency room for atypical chest pain. ECG showed aspecific abnormalities of LV repolarization, so nothing really remarkable. Myocardial biomarkers were normal or with a mild troponin increase. And echocardiography showed a normal ejection fraction with no wall motion abnormalities or pericardial effusion. So the diagnosis she had at the beginning was acute pericarditis, and that was all. Patient was sent home, don't worry, take indomethacin, take appropriate drugs, you have an acute pericarditis, nothing more to say. The problem is that it was Christmas period of 3 years ago. After the diagnosis, which was done before Christmas, she had 10 days of persistent chest pain. In that period, doctors and MR services working, of course, slower than in the rest of the year. So she waited 10 days. She had persistent chest pain. She had dyspnea and progressive fatigue. Something was wrong because regardless of the therapy, things were worsening. Let me show you MR. Look here. Short axis at the, let's say, basal mid-ventricular here. Short axis mid-ventricular and 4-chamber view. To make it interactive, look at global function. Who would say this patient has a preserved ejection fraction? Raise your hands. I would raise my hand. So we are in the range of 55%. It's almost normal or something like that, 60%, depends on how you see it. So considering myocardial function, it is a normal myocardial function. But also match it with T2 steer, third line, and with late enhancement, second line at different levels. Is there anyone who wants to comment? Again, we are 15 people, so don't be shy. If we had the microphone to make it more interactive. Nobody wants to comment? Hablamos español un poquito. No es un problema por mí. Anyway, the question is ischemic or non-ischemic? I told you this lady had a suspected myocarditis, which was labeled as pericarditis. How to differentiate between ischemic versus non-ischemic involvement? Think about, look at the images, look at subendocardial involvement, look at late enhancement, and tell me what's your idea. Who votes for the first option, chronic lateral mid-ventricular infarction? Don't be shy. Okay, no votes for this. Who votes for an acute lateral mid-ventricular infarction? Yes, we had a consistent group voting for this. Who votes for an acute myocarditis? Okay, the rest are not important, so it means you know the topic because it's a simple case, but it is an acute lateral mid-ventricular infarction. Let me go back to images. It's very basic, but it's very important, and I will show you what happened to this poor lady. There is edema here, and edema is involving transmurally the inferior and inferior lateral wall of the left ventricle. Late enhancement here involves the subendocardium, and this is completely different as compared to the myocarditis case I showed you before, and it's definitely an infarction. What's wrong here? This is her angiography done 2 weeks after the onset. What is the arrow indicating? Indica la freccia. I hear the... Yeah, it is a dissection without any procedure. So what happened to this lady? She had a spontaneous marginal branch dissection, which started 10 days before with an acute chest pain. She had symptoms of heart disease, mild troponin raise. It was confused to be a myocarditis, but unfortunately, after the exam, and it's one of those cases in which we gave the diagnosis of acute myocardial infarction before the clinicians. Cardiologists were not convinced about it, and of course, it was associated with legal implications, and you can imagine, because this lady waited 10 days for having a diagnosis, it was very difficult to do it, but MR gave us a clear insight to what was going on. Just to make it simple, differential diagnosis between acute myocardial infarction and active or acute myocarditis. We saw already several cases today. Transmural edema here, transmural late enhancement, epicardial edema, epicardial edema, epicardial late enhancement. Two different processes sharing common pathways. Second case is called the Takotsubo phenotype. Another series of cases in which MR changed completely patient's management. All patients had a clinical history of troponin raise, negative selective coronary angiography, and ST elevation with chest pain. I think, well, for those who are less experienced with cardiac imaging, but you probably have seen this angiography style or pattern, which is exactly corresponding to the Takotsubo, in which what happens is that there is a remodeling of the apical part of the left ventricle. I just stopped the movie here, which is enlarged with hyperkinesis of the basal segments and akinesis of the apex. All these cases, I won't ask you, were directly interpreted to be as Takotsubo, and colleagues didn't ask for further imaging. So the question is, why did we do MR in these cases? Or how would you approach? I won't ask you to raise your hands, this is more a discussion. Imaging is definitely necessary. We need contrast enhancement, and I will show you why. Let's start with the cine. Patient 1, patient 2, and patient 3. The third movie is stopping, but I mean, you don't miss much. If you look, they have almost the same pattern. Can I ask you if you see any difference between these three patients from these scenes? Probably not, I would say. But this tells us a lot. Same, let's say, angiographic presentations, we did MR. One of those cases, case number 2, is not the best quality, but it's real life case. And I would like you to give me the 3 different diagnoses here. Even if you're not experienced with cardiac MR, I think with the elements we had during my lecture, you could give a diagnosis. Who wants to comment on patient number 1? Again, it's a friendly discussion, so don't be shy, even in Spanish or whatever. Do you think it's ischemic, patient 1? No. Okay, there is a majority of no. Second question, do you see edema? Who votes for yes? I see edema. Okay. Let's keep these 2 information apart. About patient number 2, do you see an ischemic pattern on the first line? See. I would say yes. The image quality of T2 is not the best. There might be high signal intensity with thickening of the wall consistent with edema. What about patient number 3? Do you see late enhancement? Who votes for yes? 1 colleague or 2 colleagues, you say you see late enhancement. Where would you notice? I think signal here looks quite homogeneous. This is a 2-chamber view without clear evidence of late enhancement. But the second line is more important. What's going on here? Edema. So let's see, how would you approach this case? Do you think is it an ischemic edema? Would you say, is it an ischemic edema? The number 3. It's not ischemic. Why? It is transmural, but it is involving segments with different coronary supply. So either this patient has a 3-vessel disease or there is something different. Okay, what's your diagnosis? From patient 1? Yeah, myocarditis. For patient 2, infarction. For patient 3, it was a Takotsubo, a real Takotsubo. Why is it a nice case, I would say, or a nice series of cases? Because it shows how much MR is changing the management of the patients. Patient number 1, after a lot of questions, he admitted that he was regularly using cocaine, and I went through literature realizing that one of the effects of cocaine abuse induced myocarditis is a multifocal involvement with high edema related to the spasm of the vessel. So it's a typical case of cocaine-induced myocarditis. In patient number 2, there was a spontaneous acute myocardial infarction. What's interesting, you should not think about infarction as an entity associated only with a severe stenosis. There might even be a transmural process without evidence of stenosis because coronary spasms or microcirculation may cause that. And about patient number 3, it's very nice. We have a strange guy in our department. very famous, who is doing biopsy to everyone. So for some reasons, we as radiologists are very lucky because we have a lot of biological or histological correlation. Unfortunately, I would say patients are less lucky. But this guy, patient number 3, underwent myocardial biopsy. And this is a matching of electronic microscopy with conventional staining. What this shows here is that there is a stretching with an injury of the myocardial fiber. This is a Takotsubo. What happened in Takotsubo is exactly as being compared to a muscular injury. It's like having an injury of the leg or the arm, of the biceps or whatever. So this stretching is related to the catecholamine production, which causes rupture of the fibers and edema without late enhancement. So, talking about differential diagnosis, how do you recognize Takotsubo? You have edema here, which is typically located in the apical segments without following an ischemic pattern of distribution. You do not have late enhancement. And what is the third criteria for Takotsubo? What do you think should we look? We should look functional recovery. This patient is also called broken heart syndrome because it usually occurs after any form of psychological shock. This patient, we have a problem with the movie, sorry for that, but I mean after 45 days there is already a muscular or functional recovery. This heart is moving normally. Unfortunately the movie is not working, but you have to trust me. So, the differential diagnosis of suspected apical ballooning is incredibly spread. You should do contrast. You should consider that in some cases there is a scar consistent with ischemic heart disease or with myocarditis. And I would say 20% of clinically suspected myocarditis have different CMR diagnosis. So things are not easy, things are not straightforward. Consider it in your differential always. I see we still have 10 minutes. I don't know if you have any question, just to open discussion, or you want to move to other cases. Any comments from your side? Other cases. Still 10 minutes available. So what we saw till now. We saw 3 different Takotsubo presentation ended up to be an infarction, myocarditis, and Takotsubo. The first case was a suspected myocarditis, which ended up to be an acute myocardial infarction. I wanted to be provocative, but also to show you the incredible value of MR. We were discussing how much radiologists are underestimating this technique, this wonderful technique. At least I have the perception in this area of the world. I would push you to do it because it's really incredible. The added value it has in this specific setting of disease is really evident. What about this? This is a simple and fast case. I called it evolution of a disease. 16-year-old patient with known tuberculosis. He was an immigrant who came from the Northern Africa to Italy. He arrived in bad clinical conditions. We didn't know anything about him. He was referred for a right atrial mass depicted at transthoracic echocardiography. So, look at this first line. This time I will not comment on images. This is a T1 turbospin. This is late enhancement. This is cine. I ask you to carefully look at the pericardium, where the arrows are located, of course. And there is something here. This patient has tubercular disease, as far as we know. What would be your diagnosis? First, it's an intracavitary thrombus. It is an intracavitary primary cardiac tumor, which is not the topic I'm covering today, so it's very unlikely. It's an intracavitary metastasis. Again, same explanation, which is very consistent. You would do biopsy of it, or would you try CMR after thrombolysis? It was a difficult case because this patient had tubercular infection. We were focusing on this mass, and we decided to do a thrombolytic therapy for this patient and to do a second MRI in order to exclude intracavitary thrombus. And what happened, just to tell you how much morphology can be strange, this lesion disappeared, as shown here. First line is January 2016 or 2006. Second line is May 2016, so we did this patient last year. The thrombus disappeared, but what happened here? Look at the septum. Look at this, let's say the apical part of the septum. I will indicate it. When the tricuspid valve opens, it has this sigmoid motion, which was not present in an early phase. We also did real time in this patient, asking him to breathe in, and look what happens to the septum. Let me show you again. This is not a normal shape, it's a flattening of the septum. What happened? Thrombus and pericardial effusion disappeared. Thrombus and pericardial effusion became organized and thickened. Thrombus and pericardial effusion are still present. Thrombus is present and pericardial effusion disappeared. Of course, the second scenario occurred. This patient progressed to an organization of the thrombus, which disappeared, and a thickening of the pericardium. And he had a diagnosis of an acute tubercular pericarditis, which rapidly evolved to constriction. Cardiac catheterization confirmed pericardial constriction, and coronary angiography revealed normal arteries. 11 months after his hospitalization, this patient underwent extensive pericardiectomy, which confirmed our diagnosis. He had a complete relief of symptoms and regression of signs of constriction, and histology confirmed that there was a non-specific chronic diffuse inflammation with fibrosis. So, just to show you, we focus on the mass, and this patient with tubercular disease progressed to pericarditis, and we did the diagnosis with MR. Colleagues didn't have a clue on what was going on. And one fast case, it is a CT case. Why, you say, are you showing us a CT case in an MR meeting? Because I saw this guy last week. I was shocked a little by the case, so I want to have from you just a light diagnosis, because it regards pericardial disease. No comment from my side, just tell me what happened. Arterial phase. Look carefully at the images. Venous phase. No late phase. What do you think is it? We don't see it on MR. We may see it, unfortunately, on CT. Let me go back. Arterial and venous phase. What do you think is the diagnosis here? We assume this patient here has an aortic type A dissection. I don't know if it is visible from the screen. We did a first pass imaging showing basically nothing affecting the pericardium. In the second phase, in the venous phase, we notice that pericardium is filled with iodinated contrast material. Unfortunately, the patient died during the CT scanner. It was a cardiac tamponade just because I was reviewing pericardial disease, et cetera, and it came up that MR is, of course, not the technique for looking at pericardial tamponade. In this patient, we had this unfortunate event, and just to tell you the life of radiologists, there will be for sure legal implications related to the use of contrast in a type A aortic dissection. So we concluded with CT just to make a light and I would say shocking case. This was my last slide. My time has finished, 4 minutes remaining, but I don't think you won't ask the ticket back for this. And thank you very much again for your attention and for being here on Friday afternoon, Saturday afternoon, unfortunately. Thank you. Do you have a question?
I would like to understand why there's patients who have first, that's cases of hypothyroidism.
Yeah.
I'm confused right now.
Yeah.